the goal-oriented treatment planning. This is an extension of what we discussed. Goal-oriented treatment planning. What is the treatment goal? What is treatment goal? What I mean by treatment goal is not necessarily about harmonious occlusion, balanced occlusion, beautiful smile, good occlusion. No, there's no such a thing as balanced occlusion. When we try orthodontic treatment, we need to specify the treatment goal. Like what? We need to specify the treatment goal. Without specification of the treatment goal, we may be in trouble. Let me give you an example. Okay, let's say, I'll give an example of tipping, rotation, tipping, let's say tipping. You know the term of control tipping, uncontrolled tipping, and things like that. What's the clinical implication? What's the clinical implication of the controlled tipping, uncontrolled tipping? What's the clinical implication? Here's the clinical implication. Here's a moderate crowding case. Normal overbite and overjet. Yes, there was a midline deviation, but by tilting, so I'm not very much concerned. There's an asymmetric, no, very symmetric molar relationship, class 1, both sides. Because of the combined crowding and protrusion, we decided to pull out 4 premolars. 4 premolars. Okay? Just because there's not much of a midline asymmetry or something like that, we start leveling alignment by using regular continuous arch wire, something like this. And in order to correct the anterior crossbite on lateral incisor, we started a retraction. Following premolar extraction, leveling and alignment, upper and lower dental midline is coincident automatically because that midline deviation was by tilting. Okay? So it seems that there's nothing wrong with the whole procedure. We are just about to close the gap. Just about to close the gap. Yes. Close the gap. Yes. Close the gap. Do you find anything wrong in here? Do you find anything wrong? Yes. Huge space in the maxilla. Tiny little space in the mandible. Is there anything wrong in the molar relationship? No. Class 1. Is there asymmetry? No. Symmetric. Is there any inline deviation issue? Tiny little, less than 1 millimeter. I don't think it's a big problem. So what makes what is the main issue over here? What do we miss? What do we miss? What do we miss? So, how else the treatment should have been? There's one thing, asymmetric or uneven space, residual space in the maxilla and the mandible. No retraction in the lip. Although we were supposed to retract the lips very much. 2 things that bother me. 2 things that bother me very, very much. If at this time point, if he started to complain about the treatment outcome, I'm going to have a very sleepless night from this time on, right? and I was near the end of a space closure. What was wrong? What was wrong? Maybe you can say it's an individual variation. Even if we try to retract the upper incisor, it may be because of the severe crowding from the first place. Maybe severe crowding. So let's get each of the problem figured out. First one, asymmetric extraction space. Second one, limited lip protrusion. Limited lip correction. Do we need more retraction? Do we need more retraction in the maxilla to close the gap? What do you think? So, I guess you gentlemen, you have the answer. You have the answer. What do you find from the cephalometric superimposition? So the upper incisor was flared, very flared in the very beginning. So controlled tipping is a good treatment objective, very good treatment objective. But what else do we miss? Controlled tipping was okay, It was tipped to the lingual side as a controlled tipping. But what is missing? What dimension? How would we reverse the situation? Get out of the situation? What do we need? Do you think it's intrusion? Do you think so? Intrusion of either upper and lower incisor. Do you get it or not? Do you get it or not? Severe protrusion was supposed to be tipped to the lingual side, right? Was so that they were tipped. Well, tiny little amount of bite deepening, but it was not forgiving. It was not very forgiving. This tiny little amount of controlled tipping produced slightly deep bite, and the slightly deep bite left very uneven space in the maxilla and the mandible because they were dumped to the lingual side. Now, we cannot possibly retract the upper incisor because it's in the way, because lower incisor is in the way. Is that correct? We are troubled. We are troubled. So how do you resolve the situation? Like I told you, we have to put it aside. We have to put it aside, away from the bite, away from the bite. So, on top of anteroposterior movement, what else do we need? We have to lift it up. Lift it up. Either lower incisor or upper incisor. Okay? So what else do you do? Now we found the cause. It was because of the controlled tipping. Controlled tipping is normally good. Controlled tipping sounds good. But in this case, it should have been intrusive controlled tipping. Do you understand? It should have been intrusive controlled tipping. So we inserted additional mini screw between 5 and 6 and tried a little more vertical force factor. We made it vertical because we wanted to lift the whole 6th segment upward, not only about anteroposterior movement. We wanted to get it out of the lower incisor. We wanted to intrude the whole 6th anterior segment in order to close the gap. And also at the same time, so we are gradually closing the gap out of the lower incisor. this way. First, we were able to close the gap barely. By what? By intruding. So, on top of anteroposterior movement, you need to give it a thought to two-dimensional or three-dimensional movement many times. It's not confined in this particular case. Many times you have to think about vertical correction. What do you think about the face? It's improved. How come? Just because you close the gap? Improved. How come? How come it's improved? This is something I'm going to talk about day after tomorrow, okay? In terms of a face design. We really need to control the total arch in 3 dimensions, okay? What did we do? How did we improve the facial profile? We did something like this. So, first thing, we introduced upper incisor to be able to close the gap. Do you understand? We introduced. So the upper incisors were able to move to the distal sides without interference by the lower incisor. So we had to do something like this. And then on top of that, we were able to intrude the whole arch, to gain this much of auto rotation, to gain this much of reduction of anterior facial height. Reduction of anterior facial height. That's important for us to gain the chin volume, retraction. By combining these two, you can end up with profile improvement. Do you understand? If you don't get it, it's okay. I'll explain it again, maybe day after tomorrow. Alright? So what's the take-home message over here? We need to be a little more specific. Even if it was a regular severe crowding, premolar extraction, protrusion, it's a very simple case, but we should have been a little more specific in our treatment goal. It should have been intrusive controlled tipping. Should have been, this is a wrong example, bialveolar protrusion, class 2 division 1 with normal overbite and overjet. You're not supposed to try controlled tipping. You'll end up with a very big trouble. It's gotta be something like this. Try to compare the relative position of the root apex. What you see is the crown position. You never see the root. You never see the root apex. You are never ever able to assess the root position because what you see is the crown. Normal overbite and overjet before and after. But you understand there has been tremendous amount of intrusive displacement of the upper and lower incisor. So instead of this, it should have been intrusive incorporation of an intrusive force factor. Is that correct? Once again, have you ever experienced something like this in any of the extraction cases? Bite deepening, you are unable to close the gap, especially in the maxilla because of bite deepening, and you are in trouble. And you try some intrusive mechanics or something, but it should have been intrusive controlled tipping from the first place. This is what I mean by treatment goal. You understand? Your treatment goal must be a little more specific. Little more specific. So my question here. What do you call this? Translation. Bodily movement. Translation or body movement. You know this is intrusive translation. You know this is extrusive translation. You know, again, you know this is very intrusive translation. But I would say this is just translation along the occlusal plane. Okay? Along the occlusal plane. Again, in the case of gummy smile and protrusion. Gummy smile and protrusion. Smile arc, very good. Gummy smile. Upper incisor axis was normal. So, normal protrusion. In this normal protrusion case, we need to retract the upper incisor by translation because our upper incisor axis was 104. I'm sorry, but we're not supposed to do something like this. Controlled cheating would give rise to very severe gummy smile. And have a look. Look at the extrusive displacement upper incisor. Extrusive displacement. If you do this, you might end up with a very serious gummy smile at the end of the treatment. If you like it, it's okay. But if you don't like it, especially when you have a gummy smile from the first place, she's complaining of, you're going to try something like this. So, we included intrusive force factor from the very beginning. So, this makes you determine whether you have to extend the level arm or not. If you extend the, now this is a little tricky. If you extend the level arm, you may have an advantage of controlling incisor inclination, right? But you lose the control of a vertical displacement. Increase the level arm, your incisor will be extruded. You have a higher chance of extrusion or inability to intrude inside your segment. Is that correct? So that's the dilemma. And I'll show you how to overcome this problem tomorrow morning. Exactly. Okay? Anyhow, we are using intrusive force factor and also combining the level. Anyhow, these two force factors will give rise to resultant intrusive force factor. Gummy smile is gone.
Yeah.
Gummy smile is gone.
Yes.
What was the displacement type? What was the displacement type? Is it intrusive translation or just translation or extrusive translation? I don't know if it's intrusive. The teeth just moved along the occlusal plane. There's no extrusion nor intrusion. Pure translation to the lingual side. But how come gummy smile is gone? How come? How come? If this is the case, well, from a scientific point of view, we will call this the translation along the occlusal plane. Translation along the occlusal plane. But just because the occlusal plane has an inclination relative to the true horizontal line, if the teeth moves in this way, from the whole face perspective, it's an intrusion. So, in this area, we would have to call this just translation along the occlusal plane. But from a face perspective, it's intrusive translation, which is why we were able to reduce or get rid of the gummy smile. Do you understand? So what is the point? You'll have to clearly understand the clinical implication of each type of the tooth movement. Do you understand? So once again, to summarize this, translation along the occlusal plane means clinical perspective. From a clinical viewpoint, it is an intrusive translation. Do you understand? And many times for bialveolar protrusion that has a normal overbite and overjet in the very beginning, you definitely need the intrusive component of force to be able to maintain the overbite and overjet throughout the retraction phase. Okay? So your treatment goal has to be specified, and you never mention something like balanced occlusion, beautiful smile. No, no. There's no such a thing as a beautiful smile. Am I beautiful? Oh my God. I'm sorry to ask such an odd question. But you can exactly say, if I show my teeth, is my midline off to the left side? Many of you will agree, okay, it's off to the left side by around 1 millimeter. There is an agreement. But if I ask you, do I have a balanced occlusion? Do I have a very well leveled incisors? Do I have a very good harmonious face? You have no answer. That's stupid. That's stupid, all right? You would never ever. So your treatment goal has to be specific. What do you need for this particular case? You'll have to answer. I would need intrusive controlled tipping of the upper incisor. I would need distalization of upper left segment by 2 millimeter or 3 millimeter or something like that. Translation. I would need root movement of the first molar forward or something like that. Okay? That is visualized treatment objectives. And how many times you have to set up the visualized treatment objectives in a single case? I do that every visit. I do that every appointment. And based on that, I'll decide what kind of wire I have to use, what design appliance I have to use for that appointment. Alright? Alright, let's move on to a single tooth correction. Once again, the same thing. Bottom line biomechanism. You know any force factor that passes through the center of resistance will give rise to translation. Do you agree? Yeah. Yes? And in order to apply this rule, you have to know the center of resistance. Okay, you know the center of resistance at around 1/3 position of each single rooted tooth. And if the force goes off the center of resistance, you know it's going to rotate the single tooth. You know that very well. Now, this is the situation. You want to move the canine, to relocate the canine to this position. Already that has the answer. You want to try this rule just because it's an impacted canine. You barely were able to put an attachment on here. And just because this is what you see from a clinical standpoint, you probably want to give a power chain this way. Is that correct? Because the canine is located on the very distal side of the lateral incisor. You want to relocate the canine this way. Is this direction okay? Is this direction okay? Or this direction okay? You already have the answer. Why? Because you need the root movement. You don't want to, if you engage the power chain in here from a center of resistance, moment arm, it'll tilt the root even more to the medial side. It'll make the case much more complicated. Do you understand? Much more complicated. Okay, this is a simple impacted tooth case, but designing force system is so important. So important. Let me show you an example. 11-year-old girl was in the middle of orthodontic supervision, intervention or supervision. She had some attachment. She was referred to University Hospital for some reason in the middle of orthodontic supervision. Do you find anything wrong here?
Yeah, the displaced lateral.
Spacing?
Displaced lateral.
Displaced lateral. This one?
Not
This
that long.
This one?
Yeah.
Maybe?
Like the cane.
Canine? This is the thing. The orthodontist didn't find it ahead of time. Didn't find it ahead of time. He was troubled. The orthodontist in local area, he was troubled. Couldn't get it figured out. So he sent a patient to the university hospital. Delivered to me. What are you going to do? What are you going to do? You want to transplant? So would you believe just the simple lesson that we discussed just now can be applied to this particular case to save the tooth? Do you believe? You learn something in the class and you don't seem to apply this simple rule to your clinical practice. What do you think? What are you going to do in this case? You want to pull out the central incisor to get the dental implant work done here? Not easy to drag the canine all the way to the central incisor because it's not easy either. You want to save the canine, turning the direction all the way to back. Do you think you can do that? Not easy. Not easy. What is the third option? Not easy. Either way, it's not easy. Already 2/3 of the central incisor is resolved away. 2/3 is resolved away. What are you going to do? Okay, don't panic. Let's get back to the basic. What is the treatment goal? You need to move the canine upward. Is it possible? I don't know. At least we design. At least we design. Back up the canine. As long as you give a very intrusive force, maybe possible, even within the alveolar bone. You cannot see the canine at all. You cannot see the canine at all. This is a CPS rendering, three-dimensional rendering. So we'll try something like this. This is an object. Our force has to be like this. Just draw a line. Drawing a line is always the first step of the diagnosis and treatment planning. Draw a line, and try to reproduce that particular line using your own appliance. Okay? Open the site, and then the canine was exactly bumping up against the apex of the central incisor. And as I told you, 2/3 of the root is already gone. This was the only possible appliance I can ever think about in my mind in order to produce upwarding and purely upward force vector. I had to design a fixed lip bumper with multiple buttons, and the wire from the canine is tied up on the upper border of the lip bumper in this way. Over the border, top border of the lip bumper, it is tied on the buccal clear button of the lip bumper. So this is it. This is it. Again, we're constantly trying intrusion. So what matters is the force vector, not about the bracket type, not about the brand of the bracket, not about the company. What matters is the force design. First step, target segment, which is canine. Second, what kind of tooth movement do we need? Well, in order to save the canine, we need a pure intrusion. in order to intrude the canine, we need a single force that passes through the imaginary center of resistance of the canine. Okay, then we design it. You can probably think about this and that, and the mini screw or something, but fix the lip bumper may be doable, so we did it. And then, following the lip bumper, we designed a helical spring to move it even more to the apical side. Okay, now we barely rescued the canine out of the central incisor. Barely. It's not intruding the apex anymore. So then at this point, we inserted the minuscule here to move it aside from the lateral incisor. And this is it. Still, canine is in here. There's a single force to move the crown to the distal side. And we get this point. We get to this point. And then we'll gradually moving the canine downward and downward this way. The archwire is bypassing the central incisor because the central incisor is so weak. Now, this is going to be tedious from this standpoint. Long time leveling and aligning the canine. Still, the archwire is bypassing the central incisor in order to, once again, create the space for the canine and also correct the molar relationship. Now, class 2, slight class 2. Although it's not very total class 2, we still need interradicular minuscule. Although it takes 1 millimeter distalization, we still need interradicular minuscule because that's easier. That doesn't need patient's compliance. She doesn't have to wear class 2 elastics. As long as she tolerates the interradicular minuscule between 5 and 6, all right? Creating space without patient's compliance, bypassing the weakest tooth, alignment. All these things is possible first based on force-driven approach. Treatment goal, force vector, and based on force system or force vector, you design your plans. It has to be sequence of your treatment plan. Okay? Sequence. Alignment. Finally, you attach the brace on central incisor. This is it. Okay? How long is it going to survive? I'm talking about the central incisor. Very long. Unless she experiences some very radical periodontal problems, she's not going to suffer from that, right? She's young. So we rescued all central, lateral, and canine at the same time, right? You have a little bit of clearance between upper and lower canine because this canine is a little weak. So we intentionally maintain some clearance between upper and lower canine at the end of the treatment. She's happy. So this is the power of knowing biomechanics. Do you understand?
Yes.
So that was an example of a translation. Bodily movement. Is that correct? Bodily movement. Then tipping. 9-year-old girl respected canine in the mandible is even more challenging. Even more challenging. Are you going to save or give it up? Save the canine? You want to give it up? What do you want to do?
Maybe give up.
Save?
Give up.
I'll send the patient to you. Just take it. Just take the case. What are we going to do? Okay, this is a challenging case. This is a challenging case. So, using the CBCT analysis, 3D rendering, okay, only to find that the canine is localized between the central and lateral incisor in the mandible. Especially it's challenging because in the mandible, the bone is very thin and the bone is very complex, so it's not easy to move the tooth arbitrarily just and that way. Not easy. Bone training. Let's get back to the bottom line. Let's get back to the basic. What is our target? Canine. Okay? How is it arranged? How is it arranged? What do we get out of this three-dimensional CBCT? Okay, first thing is it's beautiful. Okay, it's beautiful. That doesn't help. I know it's beautiful, but the patient keeps asking, hey, Dr. Lee, do you think you can save my canine? Because I have to spend an additional $300 for the sake of the three-dimensional CBCT imaging. Now you give me the answer. Okay, it's tough. It's very challenging. Okay, so Dr. Lee, if you want to save it, you can save it. Oh, it's very challenging. Same answers over and over. Now, so what precious information do you think you can get out of this? What precious information? It's beautiful. That's it. What precious information? You can localize not only the tooth, but also the imaginary center of resistance. Okay? Central, lateral, canine. Is it transposition? Yes or no? If you simply focus on the position of the cusp tips, yes, it may be transposition. But from the center of resistance perspective, it's not transposed. Not transposed. Is that correct? You have a hole. So you have a hole. How do you take the best advantage of this arrangement as long as you use it? Now, the center of resistance position is okay. As long as you turn it around, you imagine turn it around. Turning is easy. As long as you give a force vector that is far away from the center of resistance, you can turn it around. You can rotate. So you can rescue the canine out of the battlefield, out of the battlefield. So you design this kind of force vector. Where does your lingual button has to be? Where does it have to be? Far away from the center of resistance, right?
Yeah.
Because you want to maximize the moment of force. You want to maximize the rotating tendency. So if you attach it by chance, if you attach a button on here, it doesn't help. You have to place a button on here. You think this tiny little difference? It's a very, very big difference. Very big difference. And from here, if you design a force vector using a mini screw in here, okay, I learned the mini screw from Janssen mini residency course, and I know how to insert it. I'm very confident. I will insert the mini screw here. And I attach the button here. And I engage the power chain between these two objects. Does it work? No. Why? Because the force vector is too close to the center of resistance. It's not going to rotate the canine. Have you ever designed the force vector in this way in your clinic? Maybe not. Not many of you design the force system in this way. Your force vector has to be far away from the center of resistance. That's what is important. That's what is important. So you design something like this.
It's crazy.
Oh my God, this is not important. This laborious, complicated, torture-like appliance is not important. What matters is that we try to reinforce the ambulatory segment because we are not able to insert a mini screw in this mixed dentition case. What is really important is, of course, that the wire is activated in this way, engaged, and then you go, keep pushing the canine to the labial side. At the end, in the best case scenario, she will end up with the end of the helical spring poking through the lip. Oh my God, she will be swollen. But that's a good consequence. That's a very good consequence. So I will tell the parents in a good case scenario, in the next month or two, she'll have a swollen lips. She will suffer from discomfort and pain. But that's a very good sign. That's saying that everything is going well. Alright?
Yeah.
Everything is going well. So this is it. I was able to expose the canine out of the battlefield. First, exposure, and then the lateral movement. How long did it take? Only a couple of months. March, now 6 months. Completely relocated. Now it's safe. So what is the biomechanics for? Efficient tooth movement. To save your time. To relieve your trouble in the clinic. Do you think it's worth thinking about biomechanics and force systems? It's worth doing it? Right, of course, it's worth doing it. I think I'll show you a little more exciting cases tomorrow. This was published in AJOGO some years ago. Two issues involved in here. One thing is infraocclusion, possibly ankylosis of the first molar. And second thing, more terrible, is infected canine. You're going to save it or not? You don't want to save it. You may want to pull out. Pull out the canine, but if you pull out, you have to think about the possible consequences. You have to think about what to do for the remaining edentulous area. You have to, if you want to pull the molar segment all the way forward or backward for the implant, or forward for the elimination of the implant, either way it'll be terrible. So basically you want to save the canine. So what do you do? So my first step, definitely you have to, just because you have to make more money, you have to charge the patient additional $300 for the sake of the 3-dimensional CBCT, right? Yes, why not? You have to make money. So you do the 3-dimensional rendering. This is beautiful. Okay, I made additional $300, and the patient will ask you, Dr. Lee, do you think you can save it? Now you give me the answer. It's your turn to give me the answer. Oh my God, what am I supposed to do? What should I do? This is a radical question. Does a 3D analysis or 3D imaging make us diagnose better? I don't know. Maybe yes, because it's very visible. If so, does the 3D analysis or 3D imaging make us treat better? Does it give a very useful information, useful answer? Does it make us answer very well? Answer better to the patient? To the patient's question? Yes or no?
Yes.
By doing what? By doing this kind of analysis. Center of resistance perspective analysis. That's terrible. But try to localize the center of resistance. Are they transposed or not? Not really. If you simply focus in the crown position, they are yes, but from a center of resistance perspective? Not really. So the same thing, as long as you turn it around the first premolar, you'll be able to rescue the canine out of the battlefield. It's the same thing. So this is a full system design, and I was able to rescue the canine. And then now we're moving it downward. And also another issue was the first molar. We tried surgical relocation once, we ankylosed. We decided to pull out the first molar ahead of time before it's too late. Pulled out, and so as to pull the second molar all the way forward. I'm going to talk about the active passive molar protraction system maybe tomorrow, okay? About the molar protraction. But today, it's all about single tooth biomechanics. Finished case this way. Do you understand how important it is to design a full system before you select the type of appliance?
Yeah.
Okay? So this was published in AJDO, I guess maybe in 2016. This is a panoramic view before and after. Now finally, after some years, the third molar erupted very well. So now I'm well off, she's well off. We are both happy about the result. Follow record 4 years after treatment. Have a look at the third molar. So something like this. So that was mostly about single tooth biomechanics, and I will definitely talk about the I'll show you more cases tomorrow. Okay. Any questions so far? Was it enjoyable?
Yeah.
All right. So we'll have a very short break. I'm happy to invite Professor Young-Chul Park, who's an emeritus professor here. Thank you very much for coming. And we will be talking about the level arm mechanics, maybe in about 10 minutes, something. So we'll have a very short break.